We're going to go ahead and get started. I think you have to move up a little bit so I can get to both. Okay. If I could have your attention, please. We're going to go ahead and start with the second session here. And my name is Linda Torma. I am on the advisory board for the Comprehensive Geriatric Education Program. I am on the MSU nursing faculty in Missoula, and I have the privilege of announcing the next speaker, who is Jeannie Osellame. She's one of my colleagues from Missoula. Jeannie's taught in the Senior Urgent and Palliative Care course for the last 3 years, which is an important course in our curriculum in terms of integrating geriatric content. It's the second med-surg type course that the students take, and Jeannie's been very influential in integrating this information into that course for us. As an instructor in this class, she chose to attend the Geriatric Nursing Education Consortium in Philadelphia. We commonly refer to that as GNEC, and we try to highlight some of the presentations from GNEC every year at our conference, and Jeannie's going to do that for us in the next hour here. From this experience, she's been instrumental in incorporating many resources and ideology about gerontology into the curriculum at MSU. Prior to her work at the university, she was a stay-at-home mom for her 2 children? 3. And before that, she worked in critical care nursing for many years at St. Pat's Hospital, which is where I originally met Jeannie way back when I was the CNS there. She received a BSN from MSU in 1988 and an MSN from Gonzaga University in 2008. Today, Jeannie's here to present to us on the topic of assessment and management of heart disease related to complex care of older adults. Please join me in welcoming Jeannie to the session.
Thank you, Linda, and I'm so happy to be here with all of you today. Yes, I go way back with Linda. Actually, Linda, she's always been a leader in nursing as long as I can remember. She even wrote a letter for me when I was going to grad school way back when. So I did go to the Geriatric Nursing Education Consortium in Philadelphia several years ago. And I have to say, when I went there, I didn't realize how many of my patients at the university we were caring for that were 65 or older. And when I went there, it was like this. It was filled with nurses and filled with energy, and I was so inspired, and I came back, and that was one thing they had, is just tons and tons of information and lots of resources, and their message is to go out and share that information with everybody else. So I'm here today to share that information with you, but the thing is I had so much information that I have a lot of stuff in here, and I hope I get through it, but if I don't, it's on the slides, plus I have a ton more information on a lot of different topics. If you're interested, you could always email me and I could send that to you. I have lots of case studies if you're interested in doing that at wherever you work. So with no further rambling, I guess I better get going since I have so much stuff. I'll show you my notes. I feel like David Letterman. I am talking about cardiovascular disease in the older adult, and cardiovascular disease, which includes hypertension, heart failure, coronary artery disease, stroke, arrhythmias, peripheral vascular disease, and valvular heart disease are major contributors to mortality and morbidity in the elderly, accounting for 40% of all deaths in those aged 75 to 85. And of all deaths in those 85 and older, and of 48% of all deaths, 85 and older. Almost 1 out of 3 adults have hypertension. It's more common in women over the age of 54 and in African Americans. And although the control of hypertension has improved over the past decade, target blood pressure goals are not achieved in the elderly. Untreated or undertreated hypertension leads to left ventricular hypertrophy, which is an important marker for adverse cardiac outcomes. The presence of left ventricular hypertrophy increased with age. In those 70 years and older, left ventricular hypertrophy occurs in 33% of men and 49% of women. Although hypertension is not an inevitable consequence of aging, there are age-related changes in the cardiovascular system that are associated with hypertension. For example, changes within the walls of the blood vessels and arteries stiffen, leading to hypertension. The aorta enlarges, and there's a decrease in compliance, resulting in increased systemic vascular resistance, increased systolic blood pressure, decreased diastolic blood pressure, and a widening pulse pressure, all leading to an age association in increase to left ventricular mass. Increased left ventricular mass places an increased mechanical demand upon the heart. After age 60, systolic BP continues to rise, while diastolic BP decreases, creating a widened pulse pressure. And data from the Farmington Heart Study, I don't know if any of you are aware of that. That's like a foreground study that's led the way in cardiac research over the years, shows that neither systolic BP or diastolic BP was superior to pulse pressure in the prediction of the risk of congestive heart failure. In addition, there are a variety of genetic and environmental factors that contribute to the development of hypertension among the older adult, including diet, physical inactivity, toxins, and psychosocial factors. Arthritis, which is a common comorbidity in this age group, is usually treated with a non-steroidal anti-inflammatory, and multiple clinical trials, NADSEDs, are associated with statistically significant increases in blood pressure of 3 to 6 millimeters of mercury, which explains increases in cardiovascular disease rates. And of all the changes in blood pressure with age, orthostatic hypotension is one of the most dangerous. With little warning, older adults may or may not experience symptoms associated with drops in blood pressure with a change in position. In the older adult, orthostatic hypertension is a result of several factors, including their muscle mass deteriorates, they have decreased venous return from the heart, and they have pooling in their lower extremities. The autonomic nervous system responds to change in position by constricting veins and arteries and increasing heart rate and cardiac contractility. So causes of orthostatic hypertension in the older adult include medications, non-neurogenic causes such as impaired venous return, hypovolemia, impaired cardiac contractility, as well as multisystem atrophy and diabetic neuropathy. But like a hypertension, orthostatic hypertension could be readily detected on a physical examination by measuring posterior blood pressure. So thus, in practice, we could be actually caring for someone who has systolic hypertension. Let's say their blood pressure is 190 over 70, but upon rising, it drops to 170 over 50, enough of a drop that it could precipitate a fall. Now we move on to heart failure, in which is a major health problem affecting more than 5 million Americans and is responsible for most hospital admissions in the elderly. The prevalence of heart failure increases with age. More than 75% of those affected are older than 65. Development of heart failure is associated with, sorry guys, but there's not that many here, so they can feel popular in this group. Male sex, lower level of education, low levels of physical activity, cigarette smoking, obesity, diabetes mellitus, hypertension, valvular heart disease, left ventricular hypertrophy, and coronary heart disease. A majority of individuals, 75%, with heart failure have preceding hypertension. So it goes to show that both incidence and prevalence of heart failure will continue to rise as our population rises. The age of our population rises, sorry about that. Atherosclerotic coronary heart disease is the most common etiology of heart failure in the United States, followed closely by hypertension alone and valvular disease. Thyroid dysfunction and excessive alcohol intake may lead to heart failure. You know, I just forgot I hadn't been doing my slides. So let me catch up with you. Well, I started with like 128 slides. Then I got it down to 90 slides. So I'm trying to do 60 slides. Okay, here we go. Also, degenerative calcific changes of the mitral and tricuspid valves are as common and can lead to heart failure. Let's go to the next. Okay, so now we know the demographics of heart failure and hypertension briefly. I have a lot more slides, but I just skipped through them so we could get to the health promotion and risk reduction. So older adults diagnosed or at risk for either hypertension or heart failure benefit from primary and secondary levels of preventative intervention. Nursing intervention for primary prevention include obtaining a thorough history and review of systems related to the cardiovascular system. It is important to document previous elevations of blood pressure or presence of new onset of other diseases. History of previous MI is an important risk marker for older adults. The literature supports the observation that older age has consistently been associated with poorer long-term outcomes, death and reoccurrent MI and heart failure following an MI. Even people 80 years old and older benefit from the treatment of hypertension, and it reduces their risk of coronary vascular morbidity and mortality. But a lot of times, these people, they get written off and they're undertreated or untreated. It's important to do the diagnostic tests, and I just listed below, in case you work in a primary care setting, the initial screening should be these following tests. And given the significance of the diagnosis of hypertension and heart failure in older adults and the association of certain comorbidities such as diabetes mellitus, the aim of a routine health history and physical examination is to detect hypertension, heart failure, and their comorbidities early. There is value to assessing height and weight and screening for obesity so that plans of care can be directed at weight reduction. If they're smoking or not, even though studies have shown that smoking cessation programs or smoking cessation recommendations at a examination is not as effective if it's at a secondary site. It still needs to be screened for and then maybe recommended to somebody else to do the smoking cessation education. The risk reduction, so age-associated changes in diastolic are usually not enough to cause overt heart failure. The presence of other comorbidities may contribute to the development of heart failure. Recently, the importance of heart failure prevention has been highlighted, and major and minor clinical risk factors have been identified. And these risk factors are as listed above. And they include older age, male, obese, and they carry on to things that may happen in more of an acute care setting, aggressive IV fluid replacement, blood transfusions, anemia. So hypertension is diagnosed on 2 or more properly measured seated BP readings on 2 or more office visits. Assessing the individual with hypertension is aimed at assessing lifestyle and cardiovascular disease risk factors. This is a point that I really think is important. The nursing assessment in the individuals with both hypertension and heart failure should identify the patient's response to treatment, which can then be used to assist that individual in management of symptoms and the underlying condition, health promotion and disease prevention activities, and chronic disease management. Understand their awareness of why they sought medical attention, how they view their condition, what is their goals, what's their agenda.